So this is about finding the needle in the haystack. So it's a real life case. A certain morning I get an email from a little bit annoyed colleague and says, well, I'm in an inconvenient situation. I did a gastroscopy for Barrett surveillance in a patient. I couldn't see anything. I did acetic acid stainings like I've seen in your presentation, and I took random biopsies, not really according to the Seattle protocol. So I have one container at 6 o'clock and a container biopsies taken at 3 and 9 o'clock. And to our surprise, the first container was fine, and the container taken at 3 and 9 o'clock had invasive adenocarcinoma moderately differentiated. So she called the patient back 5 weeks later to relook. And then she took the biopsies a little bit more in different containers. So she thought she could see something at 6 o'clock, called it a 1S lesion, no dysplasia. And then at 5 o'clock, there was a flat red area described in her protocol, no dysplasia. 9 o'clock, she could see an aberrant NBI pattern, no dysplasia. And at 4 o'clock, other biopsies were taken. So basically, they couldn't find it back again. And it also indicates how your mindset works. So once you know there is something, you may start seeing things and see aberrant NBI patterns. So you focus more on the abnormal things. So the first step we did was to revise the first biopsies, obviously, because it can be sometimes difficult. But here the pathologists agreed. So please have a look at the video. This was the assessment when the patient was referred. And tell me if you see the lesion. So I'll give you a couple of pull-throughs. So this is the white light first. I think the first thing we can see here is that the prior classification is incorrect. So it was classified as a C3M4. And what you can see is that the gastric folds come all the way up to the squamocolumnar junction. So it's a C0M4. I don't know if you could have seen the lesion already. Philip? Yeah. Here? Okay. Yeah. Yeah, exactly. And why did you see it? Why could you pick it up?
I think there's some depression or erosion around it.
Yeah. So this is indeed a previous biopsy sign, and what you could see is that around it the vasculature has changed. So there's a discrete change in vasculature, so the vessels are a little bit more irregular in comparison to the rest. So this is the LCI mode. So I've shown you all the 3 modes we had available. So I agree. So this was the endoscopy prior to the EMR, and this was the assessment. So what we first saw and what first caught my eye during the endoscopy before that is the friability after first passage. So you see that it starts to ooze just by passing with the scope. So this is what should draw your attention. And then we can see here the eye scan features also, where there is an altered vascular pattern around this squamous island. And with the eye scan OE, you can see here irregular vessels in comparison to the normal regular vessels that are here. So it's very subtle, and especially this area corresponds to the area of friability that you could see before. And then finally, if you look at the acetic acid, there is discrete loss of acetic acid right at that area of the irregular vessels. So this was really looking for the needle in the haystack. So what my conclusions was indeed that we had to reclassify the prior classification, so it was a C0M3. And then I described this indeed at 38, which was at the JA junction, 03. It's a 3 o'clock position. I could find a type 2B lesion with increased friability, irregular vascular pattern, and early loss of SC2 whitening. So this is also something very important that we try to emphasize with the Quality Improvement Committee with ESG, to use the correct terminology. So use the prior classification and also to locate and take pictures of what you see. So we performed an EMR of this, and then perhaps the pathologist can describe what they see.
So basically what you see crowding of glands in this area here. And also I would like to point out already here these horizontally arranged glands that are filled with some material here. This is the muscularis mucosa. And On higher magnification, you see the crowding, and also you see that these cells are highly atypical. They are roundish, they have nucleoli. You see the crowding up here, and this basically is an intermucosal carcinoma which invades the muscularis mucosae. And here you see these glands horizontally arranged that are filled with debris, and this is a very good sign for a invasive carcinoma, intermucosal.
Okay, so eventually we could find it. So we had an adenocarcinoma T1A-M3, which was well differentiated without lymphovascular infiltration and an R0 resection. So here, this illustrates how all these techniques can help you to find the lesion. And I think primary RFA would not have been the right way to go in this patient. So sometimes a little bit of time and looking long enough can help the patient out. Thank you.